Our second session today also deals with the Executive Order on Advancing American Kidney Health. And in this session, we'll hear a professional and an industry perspective on where we are 1 year later and the implications it has had for professionals and for industry. Our distinguished panel today starts with Professor Wendy St. Peter, who's a pharmacist from the University of Minnesota, strong patient advocate and highly knowledgeable of the need for pharmacy coordination and medication coordination and burden among patients. Professor St. Peter, go right ahead.
Welcome, everybody. I want to thank the AAKP for inviting me to talk with you today. We'll be talking about some of the barriers for optimal medication use. I'm Wendy St. Peter, and I'm a pharmacist. I'm also a professor at the College of Pharmacy of University of Minnesota. I've worked with patients with kidney disease for many years, and now I do research that focuses in on working with and making the medications that kidney patients take safe and effective. To begin this conversation, I thought I would share with you some comments that persons with chronic kidney disease or those receiving dialysis have had on medication use. And I think some of these will probably speak to you. This first one of the main themes they found out of this study is that patients were concerned about taking so many medications. One patient said, they sit in at least 2 different buckets. I bring in one bucket to the kitchen and gag down whatever, and then the next one. It's really dreadful. It's just too many. This patient is speaking to the fact that patients with kidney disease take lots of medications, and oftentimes they don't know what they're even used for. Another patient says, I take them when people tell me to take them. I'm not even sure what they are. I have to talk to all the doctors because otherwise I'll end up taking 10 pills. So frustrating for patients because they are meeting with number of different doctors, and doctors are prescribing different medications, and it's up to the patient to be their own advocate and to understand about their medications, to be able to negotiate with the physicians about which ones they should actually be taking and whether some of these medications may work against some of the other medications they're taking. So one of the other big themes was for patients that understanding the kidney disease and kidney disease process, and then making decisions to prioritize their medications. One patient said, I don't think they get the problem. When they discovered that the kidneys were bad, then I was referred to the kidney doctor, and they got me in here as soon as they could. But I have carpal tunnel in both hands, and I tell it to them all the time. They go, okay. They write it down, and then nothing happens. And so what this patient is speaking to is he has symptoms of carpal tunnel, so his wrist and his arms hurt. But when he went to see the kidney doctor wanted to prescribe medications to him to treat his kidney disease, but he wasn't feeling symptoms from the kidney disease. He wanted to focus in on the carpal tunnel syndrome. So it's a part of disconnect with what the patient's priorities are. A number of patients had issues with side effects. And so this patient said, what's on this prescription? You think they should have said, if you have any side effects such as, and then only 2 or 3 of the major ones. So talking about the physician just mentioning, at least some of the major side effects, those are not discussed. So I had to assume that there's nothing adverse except in rare cases. Well, as it turns out, that's not true because everyone I've mentioned, the edema too, they didn't blink an eye. They sort of smiled. Oh, we know. And this goes to a patient who is on a medication called a calcium channel blocker. And it typically has issues with patients developing edema or puffiness in their ankles and in their feet. And the patient was making the point is, why didn't they talk to me about that? So I understood that that might happen. And why didn't they talk to me about, what would happen if I had that side effect? What would they do? The last thing that was really a big focus was the fact that patients felt reluctant to discuss their medications with their physicians. This patient says, my list over there is about 12 different medications. I don't need to be a genius to realize that if I take 12 medicines every day, I'm going to have some side effect, right or wrong. So, what's the doctor going to say? You need it. So what this patient is speaking to is that she felt frustrated. She had so many medications. She didn't even feel like discussing it with the doctor anymore because she felt like the message was to the doctor, well, you need this medication, you need to take it for your kidney disease, so take it. So that's, again, something that we need to address in terms of helping patients with kidney disease work and deal with their medications day to day. There are some barriers to optimal medication use. We know that many doctors are involved. I think the average patient with kidney disease has 4 to 5 doctors. And those doctors oftentimes don't talk to one another. So they're all prescribing, but they don't know what the others are prescribing and whether the medication they prescribe might interact with one that another physician prescribed. Patients take many medications, average of 12 a day. And I've had dialysis patients who have been taking up to 25 medications a day. There's also not enough time during doctor clinic visits. We know that oftentimes they're limited to 15 or 20 minutes. And so there's not a time to discuss, how does this new medicine fit in with all the other medicines I'm taking? What are the side effects? What should I look out for? And the fact is that most doctors don't know about all your medications. You know, your specialty diabetes doctor may not know anything about the heart medications you're taking. And the same thing with the heart doctor may not know about diabetes. And so it's important to have somebody that understands all your medications, all your conditions, so we can look at the whole picture together. And the fact is, in the United States, with our healthcare system, we have poor communication between practitioners, between like transitions from the doctor's office to home, to the hospital, back to the dialysis unit, and those sorts of things. So what is the solution? Well, I'm going to suggest that a solution is having a clinical pharmacist on your care team. I'd like to play a video clip of a clinical pharmacist, one of my good colleagues, Dr. Anderson Haig, and this will speak more than I can on what a clinical pharmacist does.
Hi, I'm Tracy Anderson Haig. I'm a clinical pharmacy specialist in kidney transplantation. I work at Hennepin County Medical Center in downtown Minneapolis, and this is a day in the life of a pharmacist. So when people ask me about my job as a pharmacist, they often assume that I work in a community pharmacy and are shocked to find out that I actually work in a medical clinic with a scheduled appointment, seeing patients directly like a physician would. I take care of patients anywhere from 18 years of age to over 80 years of age, starting from the time they get their transplant, sometimes even before, and I'll be primarily caring for that patient. It is extremely rewarding to be able to work with patients and see a difference that you're able to make to ensure that their medications are used properly. Be able to find a medication that's causing an adverse effect, suggest an alternative medication that may work as well without the same side effect, and have that patient come back a month later with the problem resolved and the medication effectively treating whatever condition it was there for. And the patient actually recognizing that it was you, the pharmacist, who made a difference and improved their quality of life. Because I work in transplantation and transplants can occur at any time of day or night, I'm functionally on call 24 hours a day and 7 days a week. Sounds daunting, but it's very rewarding to know that I'm an integral member of the team and able to help out when they need assistance with medication management of these patients. One of my favorite patient experiences was a patient that I'd seen in clinic for the first 3 or 4 years after her transplant. And I always chuckled when she came in because on her drug allergies it listed blue M&Ms. She was doing very well after transplant, but then was admitted to the hospital 3 different occasions in a short period of time with nausea, abdominal pain, kind of non-specific complaints. And then I remembered the blue M&M issue and thought maybe this is a problem with blue dye. So I went to the hospital and asked her what her symptoms were when she ate blue M&Ms, and she said they were sort of similar to what she was experiencing now, but she hadn't had any blue M&Ms recently, so that couldn't be the case. I then called her retail pharmacy, and sure enough, there was Lake Blue number 1 and number 2 in that pill. So we worked with her local pharmacy and got rid of all medications that she was on that contained blue dye. And about a month later, I got Paige to come to clinic, and it was the patient. She said, "I just had to give you a hug. I eliminated blue dye completely from my medications and my diet, and I feel like a completely different person." That's why I'm a pharmacist. is to hear responses like that from a patient and know that I've made that kind of difference and impact on something that seemed like a very small, long shot intervention that was life-changing for my patient.
So you've met Dr. Anderson-Haig, and what I wanted to tell you is she's a special kind of pharmacist. We've got a number of pharmacists like Dr. Anderson-Haig, who have had specialized training. They've had 4 years of pharmacy school. They've had extra training beyond pharmacy school in specialty areas like transplant. So they really, what they do is, all they do each day is work with patients to figure out and resolve their medication therapy problems. So many of you have probably heard about the Advancing American Kidney Health Initiative. Well, I want to let you know that there's a number of pharmacists, clinical pharmacists throughout the country that are helping to advance that initiative through optimizing medication use. We know that pharmacists can help you learn about what medications can help slow kidney disease or keep your kidney transplant healthy. They can help figure out, how do you reduce side effects? Do you need to discontinue the drug, decrease the drug, or actually change the drug? And they can help you focus on medication issues that are important to you so you can live your life your way. We know that under this new kidney health initiative, that there's new chronic kidney disease care models that are going to be put into place that will be helping patients with chronic kidney disease or those that have a transplant. And what we want to do is make sure that pharmacists are part of that care team. And so we are working to break down barriers to having pharmacists as your partner on your care team. What I'd like to ask you to do is help me. Has a pharmacist helped you? If they have, if you would please share your story with me. I've got my name down here, so Wendy St. Peter, and my email address. And I'm asking you to send me those stories because that will help me advocate for you in this area of getting pharmacists on your team. We need your help to help us break down barriers keeping pharmacists from being on your care team. I want to thank you all for listening to me today to talk about how pharmacists can help you improve your medication use and help you prioritize your medications. So thank you very much.
Thank you very much, Professor St. Peter. Our next speaker is Dr. Abhi Sundaramoorthy from Somatus Healthcare. She serves as Senior Vice President. Somatus has been an interesting company to watch because they're on the forefront of changing kidney dialysis care in the United States. Go right ahead, Doctor.
Hi, thank you AAKP for inviting me to participate. My name is Dr. Abhi Sundaramoorthy, and I serve as Senior Vice President for Clinical Innovations at a company called Somatus. Here at Somatus, we seek to transform care delivery for patients with kidney disease. To tell you about Somatus, I have to start by telling you about our patient, Mary. Mary is a patient with underlying kidney disease who is admitted to the hospital for acute kidney injury due to prescription of a nephrotoxic medication. During her couple days in the hospital, Mary's kidney function got better. However, she developed a little bit of back pain from laying in an uncomfortable hospital bed for a couple days. Unfortunately, during her discharge team failed to look at Mary's admitting diagnosis and discharged her on another nephrotoxic medication, diclofenac. Luckily, the Somatus care team in their transitional care process was able to contact Mary and assess her, and our clinical pharmacist was able to remove that medication from her list, saving Mary another trip to the hospital. However, Mary is not alone. 18% of the US GDP, that's $3.5 trillion, is spent toward healthcare costs. Yet 1 in 3 of those dollars goes towards mitigating medical errors. In 2016, the CDC forever changed the way we view medicine by publishing medical errors as a third leading cause of death in the United States, killing over 400,000 people in hospitals and health systems. Specifically, over 50% of patients with chronic kidney disease are still prescribed nephrotoxic medications. This tells us that something needs to change. Here at Somatus, we seek to be that change. Our mission is to be the world's best provider of integrated care delivery for patients with or at risk of kidney disease. We are a company that was founded in 2016 with over 300 employees, which comprise of our care team members who actually go into our patient homes and deliver care individually to each and every one of our members, understanding barriers to achieving better patient outcomes and helping our patients get through those barriers. We serve over 21,000 lives across 6 statewide markets. Here at Somatus, we understand that while healthcare as an industry has created a very scientific approach to medical disease management and clinical management, we as an industry fall short in using that same science in care delivery. Somatus seeks to develop a new scientific model for care delivery. This starts with identification. We first identify a specific set of interventions that are evidence-based and have proven impact on both cost and quality to our patients. We then stratify our patient population based on their risk level. This may be social determinants of health, patient demographics, or clinical risk levels. We then prioritize our interventions based on them having short-term impacts, which are usually seen within 6 months to a year, or longer-term impact, like delaying disease progression, which can be seen within a year to 3 years. We then match our interventions to the right patient population, and we engage them and deploy tools to help mitigate any type of risk or barriers. And we ensure that there is a closed feedback loop and measurement system for our interventions so that we can assure that they've been deployed and that they improve our patients' outcomes. Finally, when we identify those interventions that have the greatest impact on our patient population, we codify them and we scale them across several different markets and several different patients. Here at Somatus, we realize that one great reason for patient harm is that healthcare has inherent variation built into it. We seek to standardize care in the care delivery process to drive out that unnecessary, mindless variation. So every one of our interventions is standardized through a comprehensive assessment that's delivered by our care team members in the front line. These assessments are designed to expose any gaps in patient care. Once this gap may be exposed, it triggers a workflow that leads to one specific intervention defined by Somatus. This intervention can then be deployed and a feedback loop can be closed. This eventually leads to improved outcomes such as reduced inpatient admissions, readmissions, and a delayed disease progress, ultimately resulting in lower cost, better outcomes to our patients, and an improved quality of life. We also realize that one fallacy in healthcare can be that patient care can be siloed. It can be siloed amongst teams, and it can be siloed throughout the patient's care continuum. Here at Somatus, we seek to have a continual process for measuring the patient's journey, right from their preventative care, throughout their hospital admission, and their transitions of care to prevent any type of hospital admission if it does happen. We also break silos in order to create a multidisciplinary approach to patient care. For that reason, our care teams are comprised of several different skill sets for our care members. One of our care team members is our social worker. Our social worker helps our patients with any types of psychological barriers or socioeconomic barriers that may present themselves and stop our patients from getting good care. Our nurse practitioners are well-versed in clinical disease management and bring that disease management to the patient's home. Our community health workers understand what resources may be available for our patients within their community and ensure that the patient is connected to those resources. Our clinical pharmacist monitors medications for our patients, ensures that nephrotoxic medications are removed, all medications are renally dosed, and patients are optimized. Here at Somatus, we realize the importance of being data-driven. One of the things in modern healthcare that really helps us improve outcomes is the fact that we have data. It allows us to see far beyond what our hands can touch. We can now see patients after they're discharged from the hospital. We can see them 30 days after discharge, 90 days after discharge, what happens in a clinic setting, what happens in a post-acute facility. Here at Somatus, we utilize this type of data to ensure that our interventions are appropriate and they're improving our outcomes. As you can see, this has helped us reduce our inpatient utilization and readmissions for our patients. Despite all the tools we may have in medicine and in healthcare delivery, at the end of the day, transforming care delivery requires a village. Traditionally, we've depended on providers to truly transform care delivery. And while they're still a very important integral part of our model, here at Somatus, we also introduce an interdisciplinary team where the patient and the provider are the center of the team. However, we provide resources that have not traditionally been available to patients to ensure that barriers are removed so that we can change the course of a patient's illness. The third layer that health policy changes brings is allowing patients to have choice and understanding of different types of care delivery that exist that may improve their outcomes. And finally, the single most important factor in changing the course of disease is the patient themselves. So at Somatus, we make it a point to ensure that each and every one of our patients are engaged and educated in their disease process and are empowered to speak up about what their options are, what their choices are, and how they choose to control their health. Thank you, AAKP, for inviting me to join. It is often said that coming together is a beginning, keeping together is a progress, and working together is success. So I hope that moving forward, providers, companies like Somatus, healthcare policy changers, and patients can all work together to improve patient outcomes and change our care delivery model.
Thank you very much, Doc. Our next guest is Dr. Bruce Culleton, who serves as the Chief Medical Officer for CVS Health and the Vice President for Kidney Care. Bruce is a longtime patient advocate and is spearheading CVS's entry into the kidney dialysis market in the United States, as well as the coordination of upstream care for kidney patients. Go ahead, Dr. Culleton.
My name is Bruce Culliton, and I'm the Chief Medical Officer for CVS Kidney Care. And I'd like to thank AAKP for inviting me to participate in this event. And it's a real pleasure for me to participate again this year. I'd like to first introduce all of you to CVS Kidney Care, and we're a subsidiary of CVS Health. We have 3 separate programs that help patients who have kidney disease. The first is a health services program that we've rolled out over the last 18 months. And this program is designed to identify patients with kidney disease and to help work with them and their providers for better CKD care. Some of this is done virtually, and some of this uses our predictive analytics to identify and better tailor interventions for patients with kidney disease. The second is a new initiative that we started this year in partnership initially with Satellite Healthcare. And we're a dialysis provider in a couple of cities where our goal is to be a home-first dialysis provider and really support patients and their family members for more options around home dialysis. And the third component of our business is our advanced technology business. And in this business, we are developing and right now in the middle of a clinical study to bring a new home hemodialysis device to market that's been designed to help support and grow patients who choose to do hemodialysis in the home. So CVS Kidney Care has many different policy initiatives, although our top 3 policy initiatives are very much aligned with the 2019 Executive Order on Advancing American Kidney Health. And think of these in 3 broad categories. The first is to increase patient choice. The second is to embrace innovation. And the third is to promote transplant and home dialysis. On the patient choice piece, we believe that the status quo for kidney care today is a model that's centered on dialysis providers and is focused on the delivery of dialysis to patients with kidney failure, not on the identification nor on the management of patients who have earlier forms of kidney disease. Although there are signs of improvement, patient choice remains unfortunately very limited. All too often, patients are not provided options for upstream care or options for kidney failure treatment. We are aligned with AAKP to provide patients more options within the communities where they live. In this light, we've publicly taken a position against the Better Kidney Care Act, which we believe only prolongs the status quo and removes patient choice at a time that's very vulnerable for many patients around the time of dialysis initiation. We are also embracing innovation, and we applaud the efforts of FASN, AAKP, and the federal government to bring innovation to the kidney space. Together with our technology partner, Dean Kamen, we are very supportive of KidneyX, and we'd like to publicly congratulate the most recent Innovation Prize winners. We also believe the new payment models, by rewarding better holistic patient care, provides incentives for service model innovation as well as technology-driven innovation. To that end, we also encourage our government decision makers to continue timely implementation of these models, despite calls from some stakeholders for a delay. And third, we continue to promote transplant and home dialysis in our business models. Now more than ever, more patients should be receiving care in the comfort and safety of their own home. We understand patient and family decisions related to transplant and dialysis are difficult and require time. And for that reason, we're trying to identify patients earlier using our predictive analytics. And then we tailor interventions based upon a person's risk well before the need for transplant or dialysis. We do applaud CMS for granting waivers during the pandemic that removed some of the constraints to grow home dialysis. However, we think there's a lot more that can be done and should be done. There are system barriers that make it very difficult for new entrants like us or disruptors to bring innovation to patients and offer more patient choice. We do encourage policymakers and regulators to continue to assess and remove these constraints to improve patient care. So in conclusion, I'd like to thank AAKP again, not just for inviting me and CVS Kidney Care to participate in the session, but also for all their work in bringing the patient voice to policymakers in Washington. Thanks again.
Thank you very much, Dr. Culliton. We appreciate it. Our final speaker in this section is Jay Elliot, who serves as the Chief Scientific Officer for Bayer Pharmaceuticals Cardiovascular and Renal Division. Go right ahead.
Hi, everybody. I'm really happy to be here today at the AAKP Policy Summit. My name is Jay Elliot. I work in the Cardiovascular and Kidney Division of Bayer's Medical Affairs Division in the U.S. I'm one of the leads for our investigational product, finerenone, which is currently under investigation for patients with chronic kidney disease and type 2 diabetes. So really looking forward to answer some of these questions and be part of this summit.
Thank you very much, Jay. We really appreciate your presentation and the ongoing partnership and friendship we have with Bayer Pharmaceutical. Now what we'll do is we'll ask each of our panelists several different questions that have come from patients. And Professor St. Peter, we'll start with you. You know quite well that kidney patients manage a lot of different comorbidities and we see a lot of different specialists. And because of that, we take a lot of medications and the coordination of that can be fairly burdensome. Can you tell us from your perspective how patient burden of medication can be an inhibition or a slowdown to innovation in kidney disease treatment?
That's a really good question. So as I spoke to the fact that patients have multiple physicians, multiple clinic visits, some go to the hospital, and they take lots of medications. Sometimes that feels like a 24/7 job. And I think many patients feel like they don't have an advocate that could help them figure out and wade through the system of their medications and figure out what's best for them to do. There's also, I'd say, barriers to having physicians help with that. You know, we don't have enough kidney doctors or kidney nurses to help deal with that. And so that's why it's really important to have a pharmacist as an integral member of the care team.
Thank you very much, Professor St. Peter. We appreciate it. Now over to you, Doc. You're known as a champion of patients, and you have tremendous respect for patient insights. Can you tell us how your understanding of patient insights, especially among dialysis patients, has made you such a champion for patient consumer choice?
Yeah, thank you for that question. So, as you probably heard from the presentation, we are a very patient-centered care delivery model. So this really fits in with the patient care choice model. We are centered around really educating our patients on both disease management as well as disease options. So when I say disease management, I mean things such as understanding nutrition and diet, not just related to kidney disease, but also the comorbid conditions that may be related to kidney disease, such as heart failure, diabetes, high blood pressure, high cholesterol. Also understanding medication management, understanding what the side effects might be, what the benefits might be. So we really get our clinical pharmacists to get involved in that type of education. And we also ensure that the patient is educated on their disease options and their disease progression so they could make early decisions about other treatment options other than just hemodialysis, which may have better outcomes in the long run for these patients. We also activate our patients. So for patients that are not motivated because they have they lack an understanding of their disease process, we have specific training for our social workers that can help motivate those types of patients. So in the end, we really want our patients to be empowered to really understand their disease so that they can ask better questions and they can make very informed decisions on next steps to improve their outcomes.
Thank you very much, Doc. Dr. Culleton, a couple of questions for you. First, CVS understands well patient preference and the importance that plays in patient care. The executive order made it very clear that patient preference and patient choice is central to better treatment and better health outcomes. Can you tell us how CVS plans to stay in touch with patient preferences over time and as you build out your program for kidney patients? Thank you.
CVS values and recognizes the importance of patient input and patient preferences. To date, we've been working very closely with AAKP and with National Kidney Foundation as patient partner organizations. And these organizations, both organizations, have helped us with both qualitative and quantitative research for patient preferences. We also perform our own formal market research, again, both qualitative and quantitative. Both we consider to be very important. In fact, we get many insights across many of our programs within CVS Kidney Care that influence program design. Third, we also rely heavily upon social media, not just social media posts on our programs, but also social media posts in general from patients who have kidney disease. Another way we get patient input is we have an employee base of close to 300,000 employees. As you can imagine, many of those employees also do have kidney disease, and we get input from them in a less formal but a process that allows patients within our company who have CKD to reach out to us. And finally, we've hired a couple of people within our program who actually have chronic kidney disease, who have kidney transplants. And they've been a very vocal voice that bring patient preferences to the table in our program design.
Thank you very much, Dr. Culliton. Mr. Elliot, question for you. Patients and professionals are very excited about Bayer's work in the kidney space. Can you tell us about some of the innovations that you have going on for patients and where you see the future of medicine going for Bayer in kidney medicine?
Absolutely. So as you noted, Bayer is a large global company where we're a leader in a number of different business areas, including consumer health, crop science, and prescription pharmaceuticals. We've got a long legacy from as early as the 1800s in developing novel medications, many of which are focused on cardiovascular health. So of course, everyone's aware of Bayer being the originator of aspirin. And along the way, we've contributed and made a number of innovations that have helped patients living with heart disease, cancer, women's health, and infectious disease. And for us as a company, the kidney space is relatively new. So we entered the drug discovery arena for kidney 6 or 7 years ago, recognizing that there was a clear unmet need in kidney disease, and innovations were sorely needed to improve care of patients living with kidney diseases. So our first entry is finerenone, which is a novel selective mineralocorticoid receptor antagonist that's currently being studied in large phase 3 trials to assess whether finerenone will reduce the risk of chronic kidney disease progression or cardiovascular disease risk in patients living with chronic kidney disease and type 2 diabetes. We really have the aspiration that we will become a leader in kidney disease drug development and discovery, and that finerenone is an entry point for us to work with the kidney community to find solutions for patients living with kidney disease, and that over the next few years, we really look forward to both globally and in the US, continuing to innovate, continuing to partner in trusted ways with the kidney community, including patient community and groups like AAKP, to set ourselves up for a foundation of success by improving outcomes in the kidney disease space, and really driving innovation, leadership, and bringing the best solutions to market. So it's with a great degree of mutual excitement that we're entering the space, and also at a right time because of recent policy and other decisions like the Advancing Americans Kidney Disease Executive Order last year, and with many more new innovations that had not been present for several years in kidney disease. So I think it's an exciting time overall in the space, and again, we're happy to be in it.
Thank you. Another question for you. We've been very impressed at AAKP about Bayer's efforts to capture patient preference information and patient-reported outcome data. Can you tell us what it means in terms of substantive engagement for Bayer and why the pursuit of that information is so important for your strategy?
Absolutely. So at Bayer, we have a philosophy, and it's something that we try to live and make sure is reflected in everything we do, and that is that for us to be successful in innovating and bringing the best possible solutions to patients, that we have to have the heart of the patient and the voice of the patient in all of our activities. And so that starts from the very outset of drug development, where we're studying the drug and making sure that patient input is reflected in the way that we design clinical trials, as well as understanding both globally and in all of the countries in which we work, where there are care gaps and needs, and what's truly important to the patient. And that comes from a couple of different sources. It comes from trusted partnerships with groups like AAKP and other advocacy organizations like National Kidney Foundation, where we seek to identify unmet needs and ways that we can partner to address them. And just in brief, I'll give you a specific example. We recognize that all too many patients living with type 2 diabetes are diagnosed with chronic kidney disease too late, where there may have been an opportunity to recognize and to intervene earlier to preserve kidney function. And so the evidence is clear that that's a gap for both screening and diagnosis in the clinical care community. So we've been partnering with National Kidney Foundation, other groups to educate on the importance of appropriate screening, all of which is consistent with professional guidelines. We're also extremely excited at the fact that this year there was the adoption of a new quality measure that would mandate annual screening, and that screening would be tied to reimbursement under Medicare. So this is a development that we think is going to increase the motivation to do appropriate screening and make sure that patients are identified early. And so, again, working both in concert with professional societies and advocacy organizations, as well as independently in the way that we work directly with physicians and health systems, we've been working to fund research and partner on solutions to make sure that appropriate screening is done and patients are identified at the earliest possible opportunity so they can work to manage their disease in conjunction with their healthcare provider. The second thing is that in addition to partnerships, it's also important to receive individual patient input. And that's done in a few ways. I think our team has been struck by being able to meet with and understand just the vast and very complex challenges that people living with kidney disease face. And that's motivated our team to really try harder and be humbled and struck by the opportunity to make a difference for patients living with chronic kidney disease. And then the other element being that we recognize that there are specific needs that require direct patient insights. And so an area that we're digging into is disparities in CKD care, which is clearly an area where there's untapped opportunity, because as much as kidney care in this country isn't perfect overall, there are clear disparities that are manifest, and to the extent that we can help understand and remediate those disparities, that's what we feel is part of our function as a trusted corporate partner and somebody who can work with advocacy organizations, with policy and other ways to truly make a difference in the lives of patients living with kidney disease.
One other question. Bayer has a long reputation for looking for opportunities to advance patient treatments in your pursuit of innovation. Can you tell us how Bayer's strategy fits within the executive order on advancing American kidney care?
So 2019 was a really exciting time in the kidney space, and specifically with kidney policy. We were delighted to see in March, when the initial draft of the executive order was released, and then for it to be finalized, and to see members of AAKP leadership and other patient advocates on the podium with Secretary Azar and President Trump announcing the executive order advancing American kidney health. We recognize that there are several goals and several objectives within the order, but that the first goal is directed towards efforts to prevent, detect, and slow the progression of kidney disease, and that they've set a bold aim to reduce the number of Americans developing end-stage kidney disease by 25% by 2030. This is squarely in line with our focus on developing therapies that will hopefully be demonstrated to slow the progression of kidney disease and work in novel ways to address an unmet need for patients living with chronic kidney disease and type 2 diabetes. We also feel it's very much in line with something I described earlier, the need to screen, diagnose, and intervene early in kidney disease to preserve kidney function and reduce really the terrible burden of progressing to kidney failure. As I think everybody who's in the kidney space knows, that there has been, in particular, looking at patients with type 2 diabetes and also with kidney disease, there have been very few innovations for roughly the last 20 years, until 2019 again, when the Culliton study of Invokana was released, which represented a tremendous advance and another tool in the arsenal to be able to attack and manage chronic kidney disease for patients with diabetes. And likewise with finerenone, with our phase 3 data pending, and with a hopeful approval, of course the drug still isn't approved by the FDA, that we'll be able to bring one more therapeutic option and one more tool to be able to help advance the mandate and the bold steps that were made through the Advancing American Kidney Health Act. So it's an exciting time, and we're glad to be with the AAKP on this journey.
Thanks, Mr. Elliot, and I'd like to thank all of our guests on this panel for answering the questions and for great presentations. We appreciate your time. Thank you very much.